Okay, we have a long time together this afternoon. It's beautiful out, so let's try to make this interesting. Sitting through this and participating today will allow you to be certified as a NIATEX change leader. So some of the content, you may see some of the content again, um, but it's required that I go through all of the modules in order to issue this certification, right? So we can skip over things if people feel like they've heard it a lot. But one interesting thing I always like to remind people of, particularly those of you in education, is that a person, from linguistic theory, a person actually has to hear something about 23 times, right? There's a really interesting linguistic theory called the Sapir-Whorf theory. And when you learn a new concept or you begin to learn a new concept, you have to hear about it and use it and internalize it about 23 times before one is considered to have mastery. So I take some pleasure in that, given that we're going to have to do a little bit of repetition here. And by the way of further introduction, I am the Chief Executive Officer of a large nonprofit healthcare organization. In New Haven, Connecticut, we have around 7,500 patients in 5 locations. Before that, I ran a locked psychiatric hospital that had an associated outpatient substance abuse and psychiatry practice, right? So I've literally been in the field as an administrator since my children were 2. My youngest child was 2 and she's now 40. So it's been a long time with that. And I am not, I come at this from a very practical point of view, right? This is and sometimes, and I've had this conversation with my colleagues, sometimes in implementation science, we are very consumed with studying the implementation. And it can be, and I was listening to Dr. Esserman this morning, it can be a little bit confusing to think about, how valid is our experience, right? When you start to look at only data as the way to evaluate something and you need like big data sets and all of that sort of thing, that is accurate, but that is not in the hands of most people who are doing things all day, right? So we're going to try to walk through this with a foot in both of those worlds. We'll start out with a deep dive into the principles of NIATEX, discussion and some practice with NIATEX tools and exercises. Because we're a small group, it'll be fun to actually do some things together. Some specific thoughts about starting a change team and change projects, really specific discussion of coaching and coaching strategies, and then a section on recognizing and managing resistance. So we've spoken a lot about, people who don't really want to change or systems that don't want to change. How do we try to manage that? So NIATEX was this partnership of 2 grant programs started in 2003, right? The United States federal government has an arm, the Substance Abuse and Mental Health Services Administration, that has a center called CSAT, which is for the study of substance abuse treatment. They actually put some money in the field. And the reason for doing that was in 2003, it turns out that only about 25% of people who needed treatment for any substance use disorder were entering treatment. 25%. What does that mean? It means 75% are not. Of the 25% who started treatment, more than half of them dropped out before the clinically recommended time, right? So now you have 12% of people. That's a giant implementation gap. Right, so that's where the idea for putting the money came into. And then there were a few really interesting people, Fran Cotter, Victor Kaposia. You can Google all of these people who were part of something called the Washington Circle Group And the Washington Circle Group was a think tank. And I got thinking this morning about when Miriam reminded us that because of the Fogarty program, people who are currently students in that program are studying various aspects of HIV care in the country of Georgia, and how that might lead to a really interesting collection of knowledge in the hands of a relatively small group of people. Maybe that's a think tank. Maybe the university has another role in being a think tank and sparking something like this. We have worked extensively across the United States. I'm a faculty member in the evaluation phase of another federally funded grant program in which we implemented medicines for opioid use disorder in 55 jails in the United States across the country. So here in Georgia, you don't have methadone inside your prisons, and that's not that unusual. Right? That is relatively normal. There is a movement across the world to start treating people who are incarcerated for drug use disorders, particularly because that's often how they end up in prison, right? So you saw Levon's talk this morning where he reminds us that, you know, a high percentage of people who are in the probation system actually ended up in probation because of crimes they committed related to their drug use, right? So NIATEX is a good strategy for multiple settings. Our grant in West Virginia right now is an integrated care grant where we're taking a look at the intersections between opioid use disorder, HIV, and viral hepatitis in 20 primary care settings. It is a stepped wedge design, which is Dr. Esserman's least favorite design, and mine too, I might add. Just give me all the 20 teams right from the beginning. I don't want to deal with randomization and all of that sort of thing, right? Let's just do it. But there are some good reasons for doing it that way. The seminal article that comes out of the original NIATEX collaboratives, of which I was a member, was authored by Dennis McCarty. He's at Oregon Health Sciences University. And it describes the impacts of the NIATEX model, particularly on access to care and retention in care in substance use treatment settings. So across this set of organizations, we had a look at, can you improve access? Can you improve retention without spending more money and by using these NIATEX principles? And it turns out that the answer is yes, you can do that. And then 2 years later, we still have the same data from the same organizations. So that sustainment phase was actually carried out, and that those gains were sustained over time. So it's a really interesting article to look at. Sometimes I think we feel like research doesn't have real world implications, but in this case, this was intended to have real world implications, and it did. Since then, there are more than 60 peer-reviewed publications that support the effectiveness of this model. The model has been highly effective in Central Asia and Eastern Europe, primarily through RICS grants, many of which I'm also involved with, right? So that we have tested this across this region in a whole variety of ways. And someone asked a question yesterday about, you know, cultural fit or cultural appropriateness, and it seems to be workable in the various contexts in which we've used it. I also had the opportunity to use NIATEX with Native indigenous tribes in the United States and with Asian and Pacific Islanders who are considered US citizens as well. And we have some very good results from those cultures, which are quite different, I would say, from necessarily mainstream US culture. So there's a lot of literature out there. If you want to use this kind of thing in practice, which I urge you to think about, you can find case studies that range from really small organizations to big systems. And so it depends on what your scope really is. We've done a lot of work now in mental health care, in the child welfare system, in the criminal legal system, in services to elderly people, integrated primary care, mobile technologies, and other human services settings. And I have some pages of references at the end of the slides, and I tried to reference at least one study from each of these areas so that you could have a look at it. So why now Niatex? You know, we've had several people tell us this, but I do think it's worth remembering. You know, I always try to build a sense of urgency, which is also key to Niatex. And part of my sense of urgency is, look, we can do better, right? If it takes 17 years to move what we know how to do to actually doing it, and only 14% of the innovations actually reach the phase of being implemented, you know, that's not great. Right? And what is at stake there? It's population level health. So we're still grappling with some of the same health issues that we've had for 2 decades. Right? And some of those health issues are are in the field of HIV, both identification and treatment, in viral hepatitis, in TB, right? What we might all call these things that in some countries are labeled socially undesirable diseases. They're in the fields of substance use disorders. But one of the things that we learned from doing some landscape analyses, and our group published a paper on this, the first author is Anthony Eller. I'm going to put it out there for those of you who have some level of involvement with your government here, is we don't look at our own surveillance data with an eye toward doing a good job, right? We look at surveillance data, and we've seen some of it this week, one kind of disease pattern at a time. So we looked at HCV data in the Eliminate Hepatitis campaign, right? Which is great, but I bet you if you braided that data with what we know about who's in the HIV care system, or who's been exposed or acquired tuberculosis, or who uses drugs, right? You'd have a Venn diagram where there would be some significant overlap. And your strategy in that case might be a different implementation strategy, right? So it's really important to take this into context. This is what we know about. But 17 years is a really long time. I mean, if you have a child today, 17 years from now, they're graduating from high school, right? That's what person's like, that's a generation. So it's a long time. Go ahead. Yeah, we know more than we do. That's exactly right. Right. And what happens in that result if you're an individual practitioner and you know more than you do? You're in a situation where you're kind of struggling to do the right thing, that maybe your system doesn't actually support that, or your practice doesn't support that, right? Maybe the regulatory structure doesn't support that yet. So there's all kinds of factors that contribute to that. This is a really interesting report from the Institute of Medicine. So it's simultaneously coming out with this the Knowing Doing Gap book, and Crossing the Quality Chasm. This focuses on closing that gap between what we know to be good healthcare and the healthcare that people actually receive. This study has actually been replicated, and that 17-year gap remains. It's like 16.8 years now. So in response to these big gaps, the Washington Circle Group, or this think tank of people who were primarily social psychologists, some clinicians, and engineers, who all had a personal interest in substance use disorders, which I think is fascinating. They can each tell you a story about how a substance use disorder affected them or somebody that they really love. They developed a bunch of tools to short circuit that evidence-based gap, right? What they wanted to do is make that shorter. And I can tell you that I've employed those tools rigorously since I was introduced to this in 2003, and it works. It absolutely works. I'll show you an example later. When I first went to the organization that I currently am running, we had about 1,200 people in treatment with a medicine for opioid use disorder. And within about 4 years, we had 7,500 people in treatment. What did we do? We did all of the things that we're talking about here together, right? So we became a growing or learning organization. And David Gustafson, again, my friend, is an older man now. He's the key architect here. He's probably one of the kindest people you would ever meet. And he's absolutely brilliant. And I've learned a lot from him. So Niatex is actually based on the principles of adult learning. And the principles of adult learning are worth pulling apart. We're all adults here. There's a need to know. You get to a place in your life as you're grown up, you're no longer memorizing, the multiplication tables and that kind of thing. That's the knowledge that we teach children, right? As you grow into adulthood and navigate adulthood, you need to know why you need to know something. Like, why do I have to learn this? How is this useful, right? Then there's the set of ideas about self-concept, some people call it. I would call it autonomy. I would like to be able to use my knowledge, right? And the way that people use knowledge is generally by experience, right? So I want to be able to use the knowledge that I have. I want to practice doing what I know how to do. Prior experience, did you have a good experience with trying in this particular area or not? What were your learning experiences earlier in your life? So one of the things we know about adult learning is if you just give people a protocol or a book to read or an article to read, they're much less likely to act on it than if there's some kind of group discussion, for example, some kind of consensus reached, some sort of action plan put into place, right? So you see, we've seen some very excellent projects, again, presented to us over the last few days. And I can usually pick out by looking at them, was this just the introduction of a protocol? Was there implementation support? Right? Was there knowledge that was actually passed from whoever tried to implement this in the first place? And did that change the protocol? So you get experience in kind of looking at, and Rick talks about this as services that people have but don't use. Practically every government in this region has an enabling regulation for the treatment of opioid use disorder, but the country of Kazakhstan, where I recently did a random sampling of 800 people, a respondent-driven sampling of 800 people who inject drugs. In Kazakhstan, 33% of them are HIV positive. And in this giant country with relatively high resources for the region, in which methadone treatment is legal, they have 500 people on methadone treatment. I mean, for those 500 people, that's awesome. But in terms of the epidemiology of that, is that going to change the prevalence and incidence of HIV? Not at all, right? Not even a little. Because what you need is to reach the tipping point there. So they have a service, but they're not doing a service, right? And that's, again, quite common. This is very common in primary care or so-called integrated care settings where you have access to lots of other treatment, but you're not necessarily doing these things, right? Or you're making a referral, but the referral is passive. You should go get your blood work done, is a passive kind of referral, right? And you saw a Terry yesterday or the day before presenting some data about what does it look like in primary care. And those markers are nowhere near 100%. Right? And there needs to be readiness to learn. Right? How open and willing am I to learn from others? This is an expression that Dr. Margaret Wheatley uses, who's a leadership coach around the world and someone I've studied with a lot. How ready and willing am I to learn from others? Right? That's fundamental to adult learning, and particularly collaborative adult learning. And then orientation to learning. Is it problem-centered? Is it goal-oriented? Right? This is where, again, experience comes into play. We're looking for experiential opportunities to learn, and then motivation to learn. Right? So we'll talk about that a little bit when we talk about the formulation of a change team. But I would just urge you to consider that when you create a change team, not to ask people to sit on a change team who don't want to change. Right? That doesn't get you anywhere. That's just really a boat anchor in the process, right? Just drags down the whole process. So you have a lot of structures in societies where, you have things like faculty meetings or whatever, where, I mean, who's ever had the experience where they're sitting in a meeting and they're talking about something that's really important and you've been talking about it for 2 years? Yeah, without making any meaningful gain, right? And that's partly because the meetings don't have enough structure or tools to move you forward, but also because some people in the room are not interested in change or they have a different priority. This is where ad hoc committees can be much more useful. And instead of calling it an ad hoc committee, I call it a change team. Right? Who's going to be the change team in making sure that 100% of our incoming patients actually have their blood drawn within 14 days of entering treatment? We just did this in my organization. Right? What we found out is that we have a procedure and a policy that people are supposed to get their blood drawn, but it's only happening about 65% of the time. So you need somebody to work on that. There's already a policy, there's already a procedure, right? So telling people that they have to do it isn't working. Instead, what you need to do is you need to set up a group of interested people to come up with some strategies for figuring out how to make it work. So based on the principles of adult learning. And then I always ask myself, and I ask my teams that I'm leading, like, try to keep this in your mind. What could actually go right today? When you work in public health and you feel like overwhelmed a lot of the time because we are struggling with under-resourced problems that are important, we are always talking about what isn't going well. But part of what it's important, I think, to interject into our process of being together is this question: what could actually go right today? How are you doing? What could go right today? So it's a framework that's, again, built on principles of adult learning, where if you put yourself in a different frame of thinking about the ability that you have to actually influence the outcome, that's a positive way of thinking, or in the mental health world, we might call that a strength-based way of thinking. But what could go right today? Try just asking teams that you lead or meetings that you're in, bring this up and see what actually happens. So NIATEX is a systems thinking orientation, right? We tackled the addiction treatment system across the United States. At one point in our 3rd year of developing NIATEX, we had enrolled 201 organizations across 5 states in the country, and they literally went all the way from the West Coast of the United States to the East Coast of the United States in some fairly remote parts of the country, and we visited all of them at least 3 times across this RCT. So it was a clinical trial, if you will, of the NIATEX approach. Excellent paper that came out of this, really proving the utility of the tools and the ability to actually affect a system both at the micro level and the macro level. So in a systems thinking world, this is W. Edwards Deming, and Lily also used to quote from Dr. Deming in her talk yesterday, right? Without data, you don't know anything. Well, Dr. Deming also said, people are doing the best they can. Everyone is acting as they should, given the system that they're in. Now, he also meant people who were consumers of whatever the product is, right? And in our case, that's patients. We in healthcare do not always think of people who are patients as customers, right? They're supposed to do what we want them to. And when they need us, they're supposed to come to us. Right? That's not a customer orientation. Yes, so he's working, Edwards Deming is working from a set of engineering principles here, and you can mathematically prove this, right? Your current system is perfectly designed to produce the results it's currently producing. So if you take that on face value, which is something he proved and that others have proven, if you take that on face value and you go back to the fact that only 25% of people who need treatment for a substance use disorder are accessing that treatment, now what you have is this 75% gap. He would say that's a system issue. And what happens when you do that is a lot of things. But one of the things that happens when you do that is that the blame, if you will, is equally shared among everyone. It's not the fault of the people, like a physician working in their system. It's the system, which is supported culturally, right, from a regulatory point of view, financially, et cetera. So he would say there are all these ways that you can impact the system that could ostensibly get you different results, right? And we've seen a lot of them in practice, again, over the last several days, both in their kind of mature iteration of, your whole country doing HCV elimination to the, really student level implications of people trying to study issues that they know are a gap or a problem by looking at how to re-engineer or to understand the barriers, first of all, the barriers and facilitators of how you might actually re-engineer the system. So to produce different results, we have to change the system. Niatech's tools, this is another way of thinking about implementation, particularly about implementation coaching. The aim that we set, which has to be urgent and measurable. The aim has to be expected from the people that you're working with, supported, right? You have to support them somehow as a coach, with lunch and learn, with education, with a day off to go to a conference. You have to support people somehow. Expected, supported, and rewarded. Right? Expected, supported, rewarded. Dato.
Expected. The case of probation system and linkage to OAP, screening for
Yep. It's the battery's dying.
Yeah, it's good. It's okay to ask, right?
Please.
As you go.
Yeah.
Okay. Expected. Are there cases when there are no actually expectations and we are entering the field where we might want to build these expectations, like case of probation system and needs for screening and early identification of opioid use disorder and then leakage to relevant care?
Absolutely,
they
yeah.
Actually, very few of them might really had this expectation or realize that there is a problem that they need to address.
So yes, that's a really good question. And I'll talk about that a bit, but when I say expected, it's expected of the group that comes together to solve the problem. And sometimes, like in the case of probation, they've been asked to join this collaborative, but the expectation of the collaborative is they're going to work toward scaling up the opportunity for people to enter into opioid use disorder treatment, right? And from a coaching point of view, we're going to keep them in that lane as much as we can. right? So that's where the expectation comes from. And what we gave them in the past week, on a Monday when we met with them, it seems like 3 weeks ago, on Monday when we met with them, we gave them a lot of information about why this is important, right? And now, from a coaching point of view, and Irma brought some of this up, we're going to have to keep helping them remember that, right? That's the expectation, but we're not going to encourage them to do change projects that don't lead toward, at least theoretically, that expectation. So if I set up a group of people to improve the number of people who were getting their blood drawn within 14 days of admission, that's the expectation. You know, they may not know why it's important or how to do that, but I've asked them to do that. So that's the call to action, if you will. If you look at other kinds of leadership models and that kind of thing, it's a clear and straightforward, measurable call to action. That's the expectation. We support them through things like education, but frankly, if education alone could do this, we wouldn't need to do anything else. Like, everybody knows they shouldn't smoke cigarettes. Like, it's not like a mystery, but yet some people still smoke cigarettes, right? And well, I'm not looking at you, but I mean, it's not entirely about education, right? There's a lot of, and when you think about techniques, and we talked really briefly about decision aids, when you think about what are you willing to trade off? Like, I really like my cigarette, but I'm willing to trade, you know, having more money in my pocket at the end of the week so I can do X, Y, and Z for cutting down my cigarette smoking. You know, so we have to try to figure out some of that sort of thing in the whole process of doing change projects, right? You're just moving in a particular direction. Again, in public health, we always want the bar to be 100%, and there's no such thing. I mean, it's extremely rare. Like, here we are in the United States, we've stopped mandating the measles vaccine, and we have kids dying of the measles. You know, this was a public health problem. We kind of like checked it off our list, like, we don't have this issue anymore, and it's back, right? So we don't get to 100%. Expected, supported, and rewarded. And I said, built on the principles of adult knowledge. And then, in particular, the co-production of knowledge. This is people working together to do things, not experts telling you what to do. And my work, again, with medical professionals, this is really hard. And Rick alluded to that, right? It's hard to kind of take 2 steps back and say, because you are well trained, and you know what would be useful. We can read these papers. We know what could be useful. But what perspectives do other people actually have? Why do people even start smoking cigarettes? Which is a whole different issue than quitting smoking, right? That we don't necessarily understand very well. Why do they do that, right? That might take a different kind of change project. So the principles of knowledge that gets developed by change teams with coaches, not by coaches standing here, but by coaches standing here, is context-based. That is the most important piece of all. Try to understand the environment that you're in. One country is not like the next. One town is not like the next in many cases, right? Pluralistic. What pluralism means is we talk a lot until we come to consensus. But in this case, consensus is among people who have an interest in changing. Right? So there's a difference here. When you let everybody into the process, including the people who don't want to have change, guess where consensus ends up? Right where we are most of the time. Right? Because the person's not interested in change, just continue to drag on the process. And in the interest of consensus, we say, okay. Right? So you want to make sure people who are with you in this small change team are interested in making changes. We don't know how we're going to make a change yet, but we've set a goal and we're going to try to figure that out. It's goal-oriented. Right? We're going to move toward a particular goal. This is not just an endless committee. Like you see this a lot with people in communities in the US. parents and others get together and they create campaigns. We want to end drug use. And they really care. But we want to end drug use is not a goal, right? It's nothing you can measure. Now, saying something like, okay, 2% of high school seniors in the state of Connecticut, which is actually a fact, 2% of high school seniors in the state of Connecticut have tried heroin, right? One of two of those people is actually going to develop some problems with opioids. Now, that's a fact. That's really different than just saying we want to end drug use, right? And your strategies, and parents don't even know that because it's not data that is necessarily in their kind of worldview, right? But your strategy for keeping people from using heroin is maybe not the same strategy as stopping them from smoking marijuana, for example. It might be, but it probably isn't. Right? That's what we know from some of the other literature. So when I mean goal-oriented, you want to start somewhere where you understand where you're beginning in order to see if you can actually affect a change. Principles of knowledge developed together between coaches and change team members are also interactive. So again, I would just give all medical professionals a little thought here is that it's really hard to unknow things. But just because you know it doesn't mean you should be saying it in the context of a group of people who are trying to learn together. If you're asked, or if that's your role, then of course you should bring it up. But in terms of saying this is just exactly what we should do, that doesn't really build camaraderie or consensus on a team of people, right? So this set of approaches is intended to make the goal clear, the data for the goal really clear, but keep the piece in the middle wide open. Like, let's figure out together how to reach that goal. 4 elements of working with this co-production approach. One of them is just as a researcher, so I'll step out of NIATEC's coaching for a second and be a researcher. As a researcher, you're doing 2 things at the same time, and I was talking with Levon about this a little bit earlier today. You are observing and synthesizing information, but you have to put that over here while you're coaching, where in coaching, you're kind of leaving an open landscape for the conversation to be even-handed, right? So there are plenty of people who are coaches who are not researchers. You can absolutely be a coach or a change leader and not be an academic person. In fact, it works really, really well. So there's the coach just has to sort of follow the playbook, if you will, like in a sporting kind of way. And I can guarantee you that we'd come up with some results. The elements of working with co-production: equality. Rick used equity this morning, probably a better word. Diversity, everyone's point of view is equally valid, right? Accessibility, knowledge can't be too technical because then people don't understand it. And then reciprocity, we're all involved in the conversation, right? It's primarily focused on doing implementation. So we've heard several times actions that encourage people to adopt evidence-based principles and practices are implementation strategies. This is a bundle of implementation strategies, right? It operationalizes both pre-implementation and implementation at the same time. So when you do things like nominal group technique or the walkthrough, or the things we're going to talk about, you're doing pre-implementation. You're using that for baseline data. Again, Levon's example from a timing point of view here today was perfect. He showed you the results of a nominal group technique that we just did on Monday, right? And you can see what people think the barriers are. Now you could use some of these strategies to try to address those barriers, right? That's happening, literally happening in real time. And then one key is to understand that implementation, and especially the scale up of evidence-based practices, is generally, as I said, and is undertaken by non-academic, non-scientists who need methods to evaluate what they're doing on a day-to-day basis. So I love data. I love transparent metrics. right? So if you ask somebody to do something, we'll go back to the blood drawing example. Let's say they make the change where for 3 hours every day, they're going to double staff the lab blood drawing station because they think the problem is waiting time, right? And you go from 65% of blood being drawn to 82% with that double staffing in 2 weeks, right? That's an example of a rapid change. You want to tell them that. That's awesome. Hey, this worked. Now what? Right? So often, again, when we get into implementation, we're doing these kind of long looks at data instead of helping people see the effects of their work in real time so that it encourages them to keep working. So we focus on process. This was Dr. Deming focuses on process. Customers, people are served by processes. I tell this story all the time. Maybe other people have the same experience. But I have a house payment every month. I have to pay my mortgage. And for whatever reason, I don't want to, I call them. It's just a thing. Maybe it's left over from my parents, a different generation. I call them up and it takes like 11 minutes to pay this payment every month. Literally, and they ask me the same questions. They ask me that, and I know they're going to ask me, and I do it anyway. In contrast to that, I have a credit card, one credit card that I also pay by phone. And I call them up and they say, hey, Lynn Madden, we recognize you by your phone number. Press 1 if this is you. Boop. And then they say, do you want to make a payment? Press 1. Boop. Would you like to use the same checking account you used last month? It ends in 8898. Press 1. Boop. How much do you want to pay? Last time you paid this much. You want to pay that again? Press 1. Boop. Do you want that payment to be today? Boop, press 1. So I pressed 1 6 times, I made my payment, it's over. It takes like 45 seconds, right? That's awesome. That's a huge improvement over that other clunky process, right? And it encouraged people to be more, I feel more successful. I'm way more likely, I don't put off making that phone call because it's really simple for me, right? So those are set of process changes. So to better serve your customer, now that's a credit card I'm going to keep, by the way. As I move toward, retirement in my life, I'll stop using cards and all of that. Most people do, but I'll keep that credit card. They like me. They treat me really nicely, right? That's what I believe. They make just as much money off me, no less or any more than another company that makes the process much harder, right? So that's a customer-focused kind of experience. So to better serve customers, organizations have to improve their processes. I tell a story. I work at Yale in the School of Medicine. Dr. Rick Altice is one of my best friends. I know 500 doctors in New Haven. I called in January to get a primary care appointment. My appointment is August 11th. Right? I'm not going to go because the reason I called in January, I had some questions for myself. I went to the people I know, my physician friends, and I said, could you order a blood panel for me? And I think this is going on. Can you do this for me? And they did it. And then as it turns out, I have to go to my home, where my parents used to live in Maine, because we're going to bury my parents on August 12th. I can't not go there. I'm afraid to cancel the appointment because I still want to keep it. But, I investing 8 months in waiting for something is way too long in a system that thinks it has good access. I tell you that system of primary care, David's shaking his head, yes, that system of primary care in New Haven does not have good access. That's not good healthcare access, right? And we don't want people using emergency departments because that costs a lot. Right? And I didn't need emergency care. I just wanted to make a relationship with a physician. So to better serve customers, you have to improve processes, taking the onus off individual people, like the person on the other end of the phone who helped me get that appointment. That's not her fault that I can't come until August. right? It's not about her, it's about the system. So the NIATEX model, you saw this, Dr. Altice showed it this morning when he did his Ukraine talk. This is created by my friends at NIATEX. It's really straightforward. And the most important piece of this, because you've seen this before, is right here, the aim. What are you trying to do? You have to keep that in your head. So I've seen organizations do things like invest in painting the waiting room and say, okay, that's going to improve access. And I'm like, yeah, probably not so much. It's going to make the waiting room more pleasant. But in terms of how people actually enter the organization, that won't do anything to change that, right? So people will come up with good ideas along the way, but as a change leader or a coach, you have to keep them focused on this aim. What are you really trying to do? Keep reminding yourself, what are you trying to do? And don't be afraid to ask people questions. So I don't say, it's not going to help you to paint the waiting room. I say, why do you think painting the waiting room would be useful? Right? So you flip it around and you try to appreciate where they're coming from, and you ask the why question and listen to the answer, right? And then you move forward from there. So the aim is the most important piece of all that. The tools we'll cover today, the rules: use existing resources, measure change objectively, and sustain the gains. And then we have the executive sponsor, the change leader, and the change team. So we have different roles of people in the room. Like Irma is an executive sponsor when it comes to our probation teams, but she also has a role in that as a coach or a change leader, right? So you can have these multiple roles, but what you really need from the executive sponsor, and really important if you're doing something with government employees like probation staff, is you need permission to do it. Right? That's really important. So you have to go convince someone that it's okay that you work with your probation teams around a particular goal. And then we'll talk about the five principles. But when you are aim setting, build urgency. I can't stress this enough. You have to build urgency. If you think about those of you who were around in the early days of the AIDS epidemic, right? What happened there? The governments in particular, and I know the US experienced the best, but the governments of the United States, all the way through the president, really ignored the fact that people were dying. And they ignored it for a lot of reasons, but one of them is that the people who were dying were men who have sex with men, who weren't considered valuable by the society. Well, how did urgency come to play when it comes to HIV/AIDS? It was grassroots. The people who were suffering, the people who loved them, they rose up and they said, we aren't going to take this anymore. Right? There's a famous organization called ACT UP. There's all kinds of books about this. The band Played On is a very good book. But what, as a result, more and more influential people began to be interested in the idea that this was an illness that potentially could be addressed, right? And if you think about like 1985, which is where there was any kind of real predominance of cases beginning in the US to the present day. I mean, that's what, 15, 40 years. That is not, that's 2 generations of the knowledge do gap. We've made tremendous progress. Right? So thinking about aim setting, you have to build urgency, and there's all kinds of ways of doing that. So when you go to ask a government official or the head of a hospital system about, head of a university or your department chair about solving a problem, you have to tell them why it's important. So this is an example from thinking about trying to build a very small logical approach to integrated care. So treating people in primary care. So here we go. First set of facts. People with opioid use disorder have a number of medical and psychiatric comorbidities. They're often cut off from care for HIV, viral hepatitis, depression, which heavily track with opioid use disorder, right? So in the sentence or two, you're trying to make that case. There's a ton of data behind all that. When treated in specialty treatment centers, like a methadone treatment program, they're significantly more likely to die 10 to 20 years earlier than people without opioid use disorder, mostly, however, from chronic medical conditions. Right? So they're not dying at a higher rate per se, but they're dying of treatable conditions. And they're not dying of their drug use because they're being treated for their drug use. But in primary care settings, the potential is they're going to get all of their treatment, which again, you saw from Terry yesterday. So you want to have your few facts laid out. You want to build urgency. You want to be able to say this kind of thing to whatever audience you're working with. In our probation collaborative, for example, we've tried to make it really clear that more people with drug use disorders get arrested. More people who get arrested end up in jail or prison. More people who are using drugs get HIV. And here's a way that you can interrupt that, right? So you want to just be really clear. Why are you focusing in this one place? And this can help you stick to your aim. So this is about aim setting, right? So if we go back to the NIATEX model, that aim is right there in the middle. So you have to pick something that's worth changing, and you have to build your logical sequence. How can you explain this to people? And then you have to keep centering that. You just keep that in front of everybody all the time. Stick to the aim, stick to the aim. You may change your pathway, but you're not going to change the goal, right? So 5 key principles of evidence-based predictors of change: understand and involve the customer, right? First and foremost, the number one factor every time you analyze the literature related to predictors of change. This is true. I very recently just worked with a person who completed a dissertation on patient self-management in substance use disorders. Turns out that self-management techniques, like some of the ones we were talking about earlier today, actually predict entering treatment and staying in treatment. Right? So same thing, a totally different analysis with a focused subject. This is about change in general. This dissertation was focused on substance use. The answer is the same. You have to understand and involve the customer. If you're working with 7th grade students, that's one set of customers, right? If you're working with a dyad of 7th grade students, in the project that Dato spoke about yesterday, and teachers, you got to understand the teachers as customers, right? Pull that apart. Where's the overlap? How can we really think about what that intervention might look like? You have to focus on key problems, and that's, again, where aim setting comes in, right? So when you saw that cascade in HCV elimination in the country of Georgia, there were some pieces of that were going really, really well. Those are not the places to focus. Those aren't key problems anymore, right? Where do you focus? You focus on those gaps. What's not going as well, right? So you want to focus on key problems. You want to select the right change agent. And we've talked a bit about this. Don't select a change agent who doesn't want to change, right? That's not helpful. And we all know these people. And later on, I'll talk a little about Everett Rogers' theories of diffusion. It's not that this is a group of people who aren't useful and necessary in systems. It's that they're just not the right people to make the changes, right? So I don't want you to hear that they're not useful or that there's anything wrong with them. But people have different change tolerance, and you want to pick the people who are interested in change to be on the change team. Seek ideas from outside the field and outside your own organization. That's why I think conferences like this are really useful, but also look at the literature. I mentioned it very briefly yesterday, but there's a whole literature on healthcare scarcity. There's a whole literature on scarcity in general. Like, how do you manage under-resourced areas, right? What do you really do? One of the things I think about all the time is what's efficient? When it comes to drug treatment, and I suspect also when it comes to HIV care, for example, We have this idea that every single person who enters drug treatment needs help with housing. They need psychotherapy. They need help finding a job. That is just not true. And if you really look hard at the literature, about 15% of them need that. That means 85% don't. So if you're trying to build a model that encompasses the needs of 15% out of 100, then that's not very efficient, right? So you're spending more money than you need to get to the same place. What if your model was get everybody to the medicine 100% and then figure out, what's the right pathway for the others who may be struggling inside of that model, right? So efficiency can be a really good way to think about your problems by looking at other fields that may have solved some of these issues. I mean, you can, in the US now, maybe here too, you can buy a car online. It's like so strange to me. You don't have to go and look at it. You don't have, it'll show up at your house as long as you pay for it, right? That's way more efficient than building these giant parking lots with a big building where, 6 or 7 people are standing around every single day. Some days no people come in as customers, and some days 40 people come in and there's only 5 salespeople, right? I mean, so they're thinking differently about the model itself. And they're having some success there. So seek ideas from outside the field and then do rapid cycle testing. Here's the biggest challenge. And I've worked in large healthcare systems literally all my life. We sit around in rooms and we make plans for something we're going to do 2.5 years from now without knowing if it's useful or not, without knowing if it's going to get us where we want to be. You must know, right, what the end measurable goal is. And you can be doing these kinds of understanding barriers and facilitators things right from the beginning. If you want to change a curriculum, for example, in a high school or university setting, you can start talking to students and teachers right now. So you may have test scores, which is one measure, but you also can do things like nominal group technique with them, right? You can ask them, what's it like to be in the classroom for 2 hours learning algebra? How would you do this differently? You can start to build that kind of knowledge in right from the beginning without, in general, from a strategic planning point of view, what we often do is we do this in theory, right? We are sitting around with the people who are responsible for the plan and working at it from a theoretical point of view, thinking that we know what we're doing, and we do based on our own knowledge, but it doesn't always work. The other thing that happens in a lot of public health fields is there's huge employee turnover. You lose all the good people to the fields that have more money, at least in the United States. That works, right? I mean, so they're really invested in the plan. They've been working with you for 18 months, and then they leave, and some new person joins the planning team. That's very hard. So what you want to do is do your work in real time as much as possible, even though your goal, and again, I'll go back to HCV elimination, your goal may be off in space, right? So one of the key things that we use in the NIATEX world, right? So we say, you want to do rapid cycle testing. How do you do rapid cycle testing? Just like this. And clinicians do this really well. You're already doing it every day. Plan a change based on your own data. You can do this in your life, plan a change. I want to walk more. Do the plan, okay? I bought an Apple Watch. That's my plan, right? Study the results. Did it work or not? And then act on the new knowledge. Yeah, it worked a little, but I'd still like to I'd like to walk even more than that. So now I'm going to set a timer on my phone to tell me to go do that, right? So that's a really simple example. People do this all the time in their lives. We're talking about doing this organizationally, right? Plan a change based on your own data of your own site. So when it comes to eliminating viral hepatitis, and you work in an AIDS clinic, for example, how are you going to be involved in that? That might look really different than working as a physician in an inpatient environment, what you do first, right? So plan the change, do the plan, study the results, and then act on the new knowledge. This is the hard part for a lot of us because we already think we know what's going to work. It's hard to convince ourselves, hey, that didn't work as well as I thought, or hey, it didn't work at all, right? So what are we going to do next? And it becomes a kind of discipline. So the PDSA steps, and these slides will be yours. Plan a change or a test that's aimed at an improvement. Know how you're going to collect the data. How do I know how many steps I walked before? Well, I was using this, right? Or I knew I wasn't getting up at all, that kind of thing. You need some baseline data. What's your prediction for the test? Is it going to work? Carry out the change on a small scale in real time, study the results, and then decide what you're going to do. So you're either going to adopt the change because it worked really well, or in my case with the smartwatch, I'm going to adapt the change. I'm going to set these alarms now, right? Or it didn't work at all, so I'm just going to put the smartwatch in a drawer or use it for messaging or something else, right? So that's where you're abandon if it doesn't work, adapt it if you have another next idea, or adopt it, okay? Generally speaking, we're doing this, PDSA, 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 right? You're just doing these things sequentially in real time until you get really where you want to go. Right? And then you look at whatever gap you might have, and maybe you change your aim a little bit. These change teams that I'm talking about developing exist inside of a learning collaborative to be done the most effectively. You can do single site change teams. It's awesome. They work. I do it all the time. But if you want large scale learning, like across the country, about how to do better HIV testing, it's really helpful to have a group of change teams that come together and are collaborating. That's what we're doing in probation. So we have this learning collaborative with our faculty. We've had expert panel meeting. We did some pre-work for a year or so, and now we've launched the project. We'll be doing these learning sessions once every 6 months. And each team will be doing PDSAs between the learning sessions, and then they're going to come back together and they will present their own data. So as a coach of a learning session, you're actually doing less and less over time. I mean, you're doing a lot behind the scenes, but in terms of actually standing up in front of people, they're beginning to present their own work, right? So when we look at process changes, here's just a metric, and it's been remarkable to see how many times we've actually had this experience together in the last few days. But reducing waiting time capitalizes on a person's motivation. If I can get an HIV test right now when I want to, I'm way more likely to do it than if it's harder to get there, or if it's a week away, or my doctor's appointment 8 months away. Like, I had real questions. You could have asked me, do you have any current health considerations? No, they asked me, what kind of health insurance do you have? Sure. Once I told them, they said, okay, you can have an appointment. Like, okay, you don't care really why I called you up, right? So you want to reduce waiting time. You want to reduce no-shows. People who don't show up or quit treatment, that's a lost opportunity. It's a lost opportunity for them. It's a lost opportunity for the system and for our society as a whole, right? Irma.
I have the question regarding the reduced waiting time and no-shows. When we did this NGT among probation office representatives, they mentioned that they experienced understaffing because even those probationers who are new in the system, sometimes they are in a waiting list until they come to the social worker or psychologist or probation officer. And sometimes their probation time ends up without showing up at the, because they didn't do any kind of initial assessment. Based on that assessment, they refer to their social worker or psychologist. So therefore, they have huge line of probationers, and they blame it to understaffing. So what could be kind of offered or maybe suggested in this case?
It's a really great question. Any thoughts? So a couple ways that we deal with that. One way that we deal with that would be to think about workflow. Why can't they go right away? Because someone else that you scheduled a month ago is in the time slot, but what's the percentage of no-shows? Maybe they've never measured that. So if the percentage of no-shows, for example, is 30%, that means 3 times out of 10, someone doesn't show up. You have 3 free hours. You could start saying, I'm going to see if anybody's with the social worker right now, or call up, and maybe you can go and see her. Right? So 3 times out of 10, that's going to work. And if that starts to work, maybe you think about eliminating appointments altogether. Right? So the second thought that I have about that, and these can be combined, is to ask, what are you doing at that first appointment that makes it take long? Maybe that's not necessary. Maybe it's really a workflow thing, and that the very first appointment is much shorter and just focused on whatever the referral issue is. And then there's a longer kind of appointment off into the future, right? So there's workflow issues, there are data issues that could potentially be explored. It's a great question, Irma. And then we want to increase continuation. If you're taking a medicine, please keep taking it, right? That's super helpful for yourself and for everybody else, and increase admissions. So in our toolkit, we have aim setting and coaching. We have the facilitated tools, which we're going to drill down on, the walkthrough, the nominal group technique, flow charting, and the development of SMART goals. So most of you saw nominal group technique yesterday, yeah? All right, so we're not going to spend a whole lot of time on that. But the walkthrough and all of these tools really help you understand the context and the utility or usefulness of collecting baseline data, right? So I'm going to skip over the nominal group technique. I don't want to skip this slide. Right? There are your own people. There's Levon doing Taco, Irma doing nominal group technique on Monday with the probation people. I think it was 42 ideas. 42 ideas from these probation people who think they don't know anything about, how to get people to treatment for opioid use disorder. And some of those ideas are awesome. Right? That's where this really comes from, is that you can do this kind of thing really quickly with any group of people. And part of the question asking, which I tried to focus on a little bit yesterday, part of the question asking is really critical. Once you sit a group of people whose job it is to work with people who are in the probation system in a room and say, what are the barriers to helping people get into opioid use disorder treatment? Once you ask them that, they start to think about it. Maybe it's not top of mind awareness, but we've got like 3 years with these folks, right? They start to think about it. They also know that you consider the question to be important. So when you heard Miriam asking earlier, can you use access theory to formulate a question? By all means, right? There's a whole theory out there about what limits access. So if your question is about access, go and have a look at the literature before you form your question. But you don't have to do that. We form questions literally in 2 minutes in the room as we're listening to people. So yesterday in nominal group technique, we had a lot of questions from people in various stages of publication, and we said, what gets in the way of getting your stuff published, right? In peer-reviewed journal, what gets in the way of that? That wasn't a question we made up in advance. And it was a very interesting discussion, right? With some fairly robust kind of suggestions that came out of that. Those suggestions will be typed up. That can be rolled right back into the PhD faculty. Like, here's what's on people's minds, right? Maybe we start thinking about how to restructure a little bit, or what is the process for mentoring people through a peer-reviewed publication. So nominal group technique is just a very helpful technique that promotes group decision-making. It engages everyone. You can complete it in a short amount of time, and you can get a lot of information from a group. You know the steps: silent idea generation, round robin recording of ideas, the serial discussion of ideas, and final voting. And again, shout out to the Pride team. Now, conducting a walkthrough. A walkthrough is pretty much what it sounds like, right? You're going to walk through a person trying to access whatever service we're talking about. So I have agency in here, but it could be something like HIV testing or using a vending machine in the middle of the night, right? So you want to play the role of a client or a prospective client along with a trusted other, your family member or a friend, seeking treatment or seeking a service of some kind. You create a legitimate scenario in your head, right? You know what to say if you're going to make a phone call. I know what I would say if I was going to make a phone call and trying to get into drug treatment, because I've worked in that field a long time. We know what we're going to say if we're trying to get an HIV test, right? So create a legitimate scenario. If it's a walkthrough at your own organization, it's not a secret. Walkthroughs are so useful. Tell people, we're going to try to understand this process a little better. And, you know, sometime in the next couple of weeks, one of us is going to be walking through, or a couple of us will be walking through the process. And just, you know, do it like you always would. So this is not secret shopper. And I'll tell you, even though they know you're coming and they're going to give you their best effort, you're still going to find opportunities for improvement. So let them show you their best effort, right? It's really okay. I mean, I have a walkthrough story of a woman, a pregnant woman who was an opioid user, and she didn't speak English in an English-speaking organization in New Haven, my organization. She came in with her boyfriend who did speak English. And we immediately separated from her boyfriend, because we have these ideas in drug treatment that people who use drugs are not going to tell the truth if they're sitting with their trusted others, right? So then she could barely speak, but we got through we communicate. She could speak just fine. We got through the interview, and she was a good candidate for treatment. We sent her to the finance office, which is right there. We did everything in real time. We thought we were doing a great job. And we asked her, do you work? And she said, yes. I said, okay, you know, who do you work for? Well, it turns out she works for her boyfriend's father. Can you get a letter from your boyfriend's father that he's paying you? Well, she said, yes, I can. And we never saw her again. You know, a couple things wrong with that, right? First of all, we could have and should have, and we do today, give her the treatment before we asked her about her finances. She's pregnant after all, which is a priority population. Secondly, don't separate her from the one person who's at least supportive enough to be there with her, who speaks the language better than she does. And don't ask her to ask her father-in-law to write down something that's not legal. Hey, I'm paying my son's girlfriend X amount of dollars to do X, Y, and Z. That's not a paycheck. That's a, you know, under the table kind of arrangement. And she left. And afterward, when I talked to the staff person in the finance office, she said, listen, Lynn, because I was upset. I said, you know, what happened? And she said, this is what it says I'm supposed to do. I was literally following the process that we had. which is if a person wants to have, free care, try to verify their income. So by legit following the process, we learned through this that we were doing something not only that was really wrong in some ways, but potentially putting people in danger, right? So you learn that kind of thing from a walkthrough. Your staff are going to give you the best experience they can give you, but they're still going to be following how they understand the policies and procedures to be, and you are going to find some opportunities there for making changes. And then you ask them, what do you think would make the process better for clients and for staff? You ask them afterward. And then you put together a list of client and staff needs, possible improvements that could address these needs. We're going to do a little exercise. And after the walkthrough, what surprised you the most? What surprised you the most during your walkthrough? Right? So there's a qualitative experience. What 2 things that you observed during your walkthrough would you change? So that's the process of doing a walkthrough. And now as we move toward the break, which is in 10 minutes, I'm going to ask you to do a walkthrough and then come back into the room prepared to share that with your colleagues here. So Irma, could you tell, what is it that we're trying to get them to do? The experience that we want you to try to have.
Yeah, this is just as an exercise. Lynn and I discussed maybe it's worth to look, for example, if I'm looking for the hepatitis C treatment, or if I just found out that I've been exposed to TB, because I've just eventually found that I'm the contact person of TB infected person, and I'm in horror, and I would like to find out what should I do, what we do, or maybe even I decided to quit smoking, and yeah, which is
Great, thank you. So pick one of those scenarios, right? You know you've been exposed to somebody who has TB, and try to figure out what you're supposed to do next. Or you want hepatitis treatment. Try to figure out what, now don't use your knowledge necessarily if you deliver one of these kinds of care, but try to, if you're just a person in the community and these are things that are in front of you, try to literally make a phone call right now. Use your computer or whatever to start the process, but make the telephone call and just be prepared to report out on it. Remember, when you have a look at the steps, you need a legitimate scenario, right? I was in the hospital a few months ago. I had a test for hepatitis. Someone told me it was positive, but I, was having other trouble at that time. And now, I want to follow up on that. What do I do? Right? People feel comfortable. I see puzzled looks here. Yep. Yeah.
if you are able to call.
Yes. Okay, so you still might have this kind of question on a Saturday.
Let's find out.
Yeah, let's find out. Let's just do the walkthrough, okay? Because we can't do it in person. We're sitting here in this room, but make a plausible scenario. I love that today is Saturday, right? Like everyone has Saturday, and sometimes it's the only day you have to think about things. So try doing a walkthrough, some kind of telephone call between now and the break. Go on break, and then when we come back from break, people are going to report out their experience. So this is what I'm gonna be asking you to report on. What surprised you the most? And what 2 things that you experienced or observed would you like to potentially change? Okay?